So the next paper is on retrospective study of demography, clinical characteristics and outcomes of DSAEK graft rejection by Dr. Shalini Singh.
A very good afternoon to everyone. So I shall be presenting DSEC graft rejection, a retrospective study of demographic profile, clinical characteristics and outcomes. So as we all know, the most popular technique for posterior lamellar keratoplasty today are DSEC and DMEC. But in a recent study conducted in US, the number of eyes undergoing DSEC was 20,000 whereas DMEC is 7,000. Hence, concluding that DMEC is still the surgery of choice, especially in eyes with complex anterior segment anatomy. So it is very important for us to understand anything which influences the outcome of DSEC. This is one of the study published by Das et al., according to which corneal edema post-cataract surgery is one of the most common indication at a tertiary care facility in South India. So coming to the purpose of our study was to evaluate the demographic profile, clinical characteristics and outcomes of DSEC graft rejection. It was a retrospective analysis of patients diagnosed with DSEC graft rejection from May 2012 to February 2019. 61 eyes of 61 patients were included, among which 6 patients were lost to follow-up after the first episode of graft rejection, hence they were excluded. A standard DSEC surgical technique was pre-cut tissue was used with a donor size of about 8 to 8.5 millimeter, and the DSEC lenticule was inserted into the anterior chamber using Sheets glide. Postoperative management included topical broad-spectrum antibiotic and steroids after surgery, which were tapered gradually and maintained at once or twice daily dose. Now shifting our gears to the results obtained in this study, the mean age in this study was noticed to be 52.44 with a range from 12 to 83 years. Females at 31.4% and male 68%. Laterality, there was no significant difference noticed between the right and left eye. In indication of DSEC, prior failed graft, that is post-penetrating keratoplasty or endothelial keratoplasty, was the most common indication noticed. One of the striking features which we noticed in this study was inflammatory conditions like toxic and viral endothelitis and iridocorneal endothelial syndrome had a high percentage of graft rejection. Coexisting parameters and comorbidities. About 64.81% of patients had associated comorbidities, among which secondary glaucoma was the most common comorbidity noticed. Clinical features, the endothelial immune response in a DSEC graft rejection, according to a paper by Price et al., is noted to be more subtle. In fact, in their group, most of the patients were picked up with graft rejection on routine examination. On the contrary, most of our patients presented to us with clinical complaints, and the most common clinical feature noticed was diffuse corneal edema, followed by keratic precipitates. And only one of our patients had a very severe grade 4 reaction with about 1 millimeter of hypopion. The time since surgery, most of our patients presented with DSEC graft rejection within 6 months to 1 year. Now the graft recovery in our study subject, about 31.48% of patients did not recover, 46.3% patients recovered completely, and partial recovery in 22% of the patients. So we did a risk factor analysis for non-recovery among the patients. So first, duration of symptom. Patients who presented to us within 7 days of graft rejection and later to 7 days, and when this analysis was done, as we can see from the p-value, that it was statistically significant that patients who presented within 7 days had a better chance at recovery. Number of transplants done before did not have an effect on graft recovery. Neither did IV methyl prednisolone administration. Many of our patients, when presented to us, were using topical steroids, and some of them were not on topical steroids, but using topical steroids when complaints started did not have a significant role in graft recovery among this study population. Coming to endothelial cell loss rejection, the endothelial this is one of the clinical photograph of our patient where we can see the cell loss after a rejection episode was almost of 50%. So when mean value was calculated, it is almost 38.87% of cell loss noticed in most of our patients. So the factors influencing graft recovery according to this study was young age, poor visual acuity at presentation, and later presentation, that is almost after 7 days. When compared to other studies, our study had DSEC graft rejection in a younger age, that is 52.44. Indication of DSEC in our study population was failed graft. And as we can see from this table, ocular comorbidities, that is secondary glaucoma, was the most common association, which is similar to reported in other papers. Time point of first rejection was 3 to 12 months, which is again similar to the results obtained from other studies. Thank you.
Thank you. I just wanted to ask you one question. You said there are one patient having hypopyon.
Yes.
So how do you correlate hypopyon with graft rejection?
Sorry, ma'am, I did not get your question.
How do you correlate hypopyon with graft rejection? Was it a graft rejection or what? It was some endogenous infection?
No, it was hypopyon because when the patient presented to us, he had significant corneal edema. There were keratic.
Normally during graft rejection, you don't see hypopyon.
Yeah,
so could it be some inflammation inside, inflammatory hypopyon, which is being considered as graft rejection?
That patient was a patient, like the prior indication for the patient for DSEC was pseudophakic bullous keratopathy, and this patient had developed hypopyon after, like, graft rejection after 3 months, and this was a patient we had given IV methyl prednisolone also, and I think 2 days later itself he had completely recovered. So we did not correlate, like there was no other inflammatory pathology suspect.
Thank you. Thank you, sir.
One question from my side.
Yes, sir.
When endothelial line of rejection will happen? Graft rejection.
Sorry, sir.
Endothelial lining of graft rejection, when it will happen?
When it will take?
He meant to ask, in case of rejection, at what point of time after rejection you can see endothelial line of rejection? I mean, how many days or immediately after in the acute phase, immediately you start seeing the line? That's what he meant to ask.
I'm not sure.
So that was rejection line.
Yes, ma'am.
When will it appear? At what stage? The first day of diagnosis, you see a line.
On first?
Day when you see the patient.
No, sir. No, it at least takes 3 days for the endothelial graft rejection line to be seen.
Come to any conclusion why glaucoma patients are having higher rate of rejection, or it's just because of altered immunity because of using drops, or or the previous pathology, maybe complicated cataract surgery or whatever, which has already damaged the trabecular meshwork? So any common factor or anything you could find?
So actually the most of our patients, like where we have seen secondary glaucoma, they have developed glaucoma like after, many of them were associated with failed grafts after post-penetrating keratoplasty or after endothelial keratoplasty, they have developed secondary glaucoma. So that was one of the thing. Complicated cataract surgery, no, I don't think we came across.
Okay.
No, not complicated cataract surgery. Most of them were mostly just secondary glaucoma developed after
So
graft.
you mean to say the glaucoma itself, or probably the drugs, or whatever we use to treat the glaucoma, that has predisposed for them to cause the rejection more?
It could
Maybe
not.
altered ocular surface following the frequent use of glaucoma drugs?
Yes, that could be one of the factors.
Just a hypothesis, yeah.
Yeah, that could be one of the factors, but apart from that, even more glaucoma patients, their aqueous humor itself is also altered. They have
Right.
more inflammatory mediators in their aqueous humor, so that could also be one of the cause that why they are more predisposed to graft rejection post-DSEC. But it is just a hypothesis, we have not come to any